All right, welcome to 225. We're going to go over the review guide that is up here on PowerPoints. It's also listed on Blackboard. Your exam next week will be will be next week, 1 week from today. It'll be in here as we're moving forward. And so we're going to go through the review, and I will also tell you that again, things are looking good as far as for me health-wise, but this coming Wednesday, I will have to be out of class the whole day. So we will not have 225 on Wednesday of this week. If we don't get through the review today, and I don't think that we will because there's quite a bit to it, I will finish recording it and get it uploaded hopefully later tonight or first thing in the morning, so that you will have it and you'll have adequate time to go through it. Yes, ma'am.
I heard of the grapevine that your cancer didn't spread.
No, it did not. I had both a CT and again, I welcome you to ask me questions about it. I'm not been secretive. Had both a CT to look for if there was anything in any of the abdominal organs as well as a bone scan, which worried me a bit because it is a high-grade cancer. Probably about the only high-grade thing about me. But the high-grade cancer does have a tendency to go into the bone really, really quick, but there was none. And so I met with my doctor. I got to do a little bit more testing, and he said most likely radiation with a 5-year survival rate of 95%. And I immediately thought of you all, and I knew none of y'all would turn down a 95%. And I said, hey, that's good enough for me too. So thank you for checking. Yes, it has not spread anywhere else, and I'm very grateful. And I'm thankful for you guys as well. So just keep being the way you are most of the time. Most of the time. All right, so let's get started here with our review. All right, so some important things that we need to know, and your exam will be based upon this review guide, and you will have seen almost all of these slides at one other time. When we're talking about an adverse effect, what are we talking about from the realm of pharmacology? Yeah, so it's a bad effect that comes about from it. Now, what's the difference between an adverse effect and a side effect?
Side effects.
Hey.
Adverse effects are ones that are undesired, and side effects are what you know is going to happen.
Okay, so good. So let me add a little more to that. So you're definitely right. An adverse effect is definitely an undesired effect, but it's also one that, we didn't see that one coming. Okay, so it's something that kind of pops out. And a side effect is much like Hayden said, is it's going to be something that we know typically happens. So for example, you give a patient nitroglycerin, what is the number one side effect that they're going to complain of? Headache. How do we know that? It's just a normal side effect that comes about. Antagonism. What do we mean by antagonism with medicine? Say it again. It works against it, okay? So if we have an antagonist, it works against it. Narcan is a narcotic antagonist. Therefore, then, what is it? It's not on here, but what is an agonist? It makes something happen. You could make the argument that insulin is an agonist in that it opens up the receptors on the cell to allow glucose to go in. Bolus. What's a bolus? It is a bunch of fluid that we're going to give. Or we can also give a bolus of medicine. Now, typically our medicine's not a big bunch, but now that's the same thing as a large amount of fluid. But let's say that you're going to give a bolus of adenosine. Trust me, you're not going to be given a large amount of adenosine. We give it fairly quickly. So it's a certain amount, particularly in, this is one of the things that you want to know about as far as the role and the situations that we would utilize these terms in that a bolus of fluid would be a large amount of fluid, okay? Those of you that are in trauma, you're getting ready to learn about that formula of how much fluid we're going to give in a trauma patient. But a bolus of medicine would be, we would be giving it fairly quickly. Contraindications, I think everybody knows, we don't give the medicine if there's a contraindication. Now, the other thing I want to kind of add on to this is that you have absolute and you have relative contraindications. An absolute contraindication is, Isabella, we don't give the medicine, period, end of story, okay? You got a patient with a blood pressure of 70, I don't care how bad his chest is hurting, we're not giving nitroglycerin. That's an absolute contraindication. Absolute contraindication would be, Richard, you got a male patient that has taken Viagra 4 hours ago and now his chest is hurting. He's not getting nitro. That's an absolute. A relative contraindication would be, we may give it or we may not give it. For example, we get a patient that's taking Viagra, but now he took it 18 hours ago, still probably going to call your doctor, your med control, and he or she is most likely going to say, okay, what's the blood pressure? Well, if the blood pressure is high enough, they're probably going to say, okay, give them one dose and then transport. Don't give them another one. That's a relative contraindication. But if the blood pressure is low, even if it's above 90 and they took Viagra 18 hours ago, the chances are doc's going to say, no, just watch them or give them some other type of pain medicine that we'll cover a little bit later on. A depressant comes about just basically to dampen things down. We're not only talking about with depressants as far as the mental activity, but we can have a respiratory depressant, which slows down respiratory. We can have a cardiac depressant, which slows down that area. Hypersensitivity is nothing more than another word for allergy. Again, we're getting ready to move into classes of medicine, and so if I ask you for a contraindication for a medicine, please don't list allergy or hypersensitivity because that's going to be true for everyone, okay? Idiosyncrasy, not idiotsyncrasy, but idiosyncrasy. What is an idiosyncrasy? Yeah, it's something that happened and you just simply, it's kind of like, not really sure why that happened, okay? And so nothing's coming to mind right now, so I don't want to spend a whole lot of time spending on examples if you understand. Indication is simply why we give something. Patients having chest pain, that's an indication for nitro. Potentiation. What happens when we potentiate a drug? Claire.
So this is more like a piggyback concept. So
Bless you.
you apply one medicine to affect another, and it.
Perfect. So we give one medicine to make the other medicine that we've already given have stronger effects. It used to be when we gave morphine, we followed it up with Phenergan. The reason being is that it made the Phenergan a lot stronger. Made the morphine a lot stronger without the added risk of respiratory depression. So the Phenergan potentiated the morphine. Refractory. Refractory simply means it does not react to the medicine. So if you are staying with our theme today, it seems to be for me with nitro. If we're giving nitroglycerin and we give our 3 doses and our patient's still having chest pain, we would report that our patient their pain is refractory to 3 doses of nitroglycerin. It did not work. Side effects, we know. Stimulants, you should know. The big thing I'm looking for with stimulant is that it activates which nervous system? Sympathetic nervous system, okay? A depressant would activate the parasympathetic nervous system. Synergism. Not quite. Not quite. Claire?
Okay, so it's a combination, we can do it at the same time instead of one after the other.
Yeah. So basically with potentiation is we give one medicine and then we give another medicine shortly thereafter to make the first medicine stronger. With potentiation, we see this it's kind of like the example I used in EMC 110 today. Normally, 1 plus 1 equals 2. But in synergism, 1 plus 1 equals 10. And the best example, and synergism is not always a good thing. The best example I can give you is that if you take a prescribed dose of a benzo, of Valium, probably not going to hurt you. If you take a normal alcoholic drink, probably not going to hurt you. You take both of them together, you wind up like Marilyn Monroe, dead, because the effect is intensified. The effect of the benzo is intensified, and the effect of the alcohol is intensified. And so basically, you stop breathing.
Because they're both depressants.
Pardon?
Is it because they're both depressants?
Yeah, that's true, but now you could have the exact same thing come about with a stimulant. So it's not just a depressant. I'm just trying to think. Go ahead, Richard.
It also largely has to do with the way most benzos, especially like, for example, the razepam work, is they trigger the exact same receptors that alcohol does. I actually have to be really careful because I also take Adderall, which also increases the effect of alcohol,
Yes,
and I take the razepam, so I have to
balance them out.
really watch.
Yeah, you got to watch them. So.
Is it just like a shock to the receptors, like regardless of what the effect is?
Well, it's basically kind of like, let me try to think here. You would think this is Friday with my brain not working. It's basically if you add one chemical to the next chemical and it explodes. So for example, let's say you've got water and acid, okay? Acid in its container is fine. Water in its container is fine, but you pour acid and water together and they're going to explode just because of the reaction. And that's what synergism is you get an overwhelming reaction by the combining of two or more drugs. All right? Therapeutic action is very similar to therapeutic window, which basically says this is the level at which the medicine becomes helpful. That's your action. Tolerance is what I've built up for Devin.
Don't worry, I'll fix that.
So tolerance means that it requires more of the same medicine to be able to come into play here. All right? Questions on these. Now, in your exam, I'm not going to give you any scenarios as per se, like I do with 110, like I do with the other ones. These are basically, because we haven't really gotten into the medicines, basically. I want you to know the definition. So I may ask you for short answer, I may ask you for matching or multiple choice, but it's just going to be really straightforward, Isabella. Okay? All right. Absorption is the process of the movement of a drug from its application into the target, into the body, and the delivery of it as far as when it gets to the target site. If we put a medicine on our skin, we know that it can get absorbed through the skin, but it's going to take longer for that medicine to begin to work than if it is injected IV, or if we take it inhaled, because it gets into the alveoli, it moves very quickly over into the capillary bed, and now it's basically like an IV drug. So understand for your exam that absorption is just simply how the drug gets into the body and gets to the target site, as well as the different things that affect absorption. Number one, a fat-soluble drug will get absorbed much quicker than a water-soluble one will. Why? Because fat is closer to the composition of the body. So the body recognizes this fat-based drug, And actually, a better word for that would be oil-based rather than fat-based. Because when you're looking at it, it's kind of like, I can't tell the difference between this being water or not. But the body simply recognizes it and absorbs it much quicker. The concentration of the medicine. Most of the time, the more we give, the quicker it gets absorbed, except when we're taking it internally. So many times people will have a headache and they're thinking, the prescription says to take 2 Tylenol. My head hurts really bad. I want it to go away quick, so I'm going to take 6 Tylenol. It doesn't work that way when we take oral medicines. Again, largely because of first pass metabolism, which is also a phrase on here. It's only going to hurt your liver when you do that. Now, if we give a higher loading dose IV, now it's going to get into the system much, much quicker. pH of the medicine. The body likes to be between what pH? 7.35 to 7.45. Now, in between that normal range of the body, is that 7.35 to 7.45, is that a little bit acidotic or a little bit alkalotic?
Acidotic.
Boy, I hear it all over the world. 7 is neutral, okay? Say it again. So if the pH goes up, does that mean we have higher acid content in the body or lower?
It's lower.
Okay, so you're moving to a base. So basically what we're looking at here is that the more acidic a medicine is, the quicker it gets absorbed in there for the reason that you just said. It kind of offsets the alkalinity of the body, okay? The alkalinity of the body. So yeah, very good. So it is a little bit on the alkaline side. Site absorption, okay? If we give a patient an IM medicine, it goes into the muscle. Remember, the muscles have lots of blood vessels in them. Therefore, it gets dispersed, and through the exact same process as we see when we take a medicine that goes in through the alveoli, then now we begin to see a more rapid uptake than if we're only going in and giving a sub-Q dose. Why is that? What are we injecting the medicine in when we give a sub-Q administration of epinephrine? What makes up the subcutaneous layer? Say it again. Epidermis, and what's underneath the epidermis? Say it again. Fat, yeah. There's almost no blood supply in fat. So I'm going to hereafter be known as not being fat, but I'm just going to be known as I'm overly subcutaneous. And so as you're giving that medicine and you're putting it into the sub-Q area, you have a much slower onset. And we do that sometimes when we want the effect to last longer. The absorbent surface, basically a larger versus smaller surface area. If we give and we rub it on the skin, even though if we were to rub it all over the skin, that's going to be much smaller surface area of absorption than if we breathed it into the alveoli. Why? Because if we took the alveoli and we separated them out and we laid them out on the floor side by side, the surface area of the alveoli would cover a tennis court. So you have much larger surface area of the alveoli than you do even with your skin. Blood supply to the site of the absorption goes right back to what I said a while ago about giving a medicine IM. Blood supply is pretty good to the muscle as opposed to giving it sub-Q. There's not much blood in that area. Bioavailability, how quickly the medicine becomes changed into what can be used. Keep in mind that there's only a very few medicines that when we inject it, that when it gets to the target tissue, it's the same medicine. So as it goes through the body processes, it gets changed. And now, if it becomes, how quickly that comes about determines how quickly it gets to the target tissues. Any questions on that? I know I'm going quickly because I got a lot of material to cover, but I don't want to leave anybody standing outside in the cold. All right, don't hear any. What's half-life?
How long it takes for the body to basically eliminate half of the effective medicine.
Excellent. So that's a good definition. How long does it take for the body to drop the concentration, Claire, to 50%? How many half-lives does it take for it to be considered eliminated from the body? 5. Half-life is a favorite topic of mine. Did I tell you half-life is a favorite topic of mine, and therefore I have a tendency to like to ask questions about it? So you've been warned. You've been warned. Distribution. As with medication absorption, how quickly the medicine is distributed depends upon your cardiac function. So if the heart is in good shape and we've got good cardiac output, then the medicine is going to get to the target organs better. This is particularly important when we're looking at patients that may be in, let's say, like cardiogenic shock. Now, I realize that dopamine is falling out of favor, and we'll still learn about dopamine, but we'll also learn about push-dose epi. But cardiac function, in cardiogenic shock, cardiac function has pretty much gone down the toilet, which means you got to watch the administration of dopamine really, really quickly because it's got to get into the peripheral arterial system in order to be most advantageous for the body. If you've lost a third of the pumping mechanism of the heart, that's going to be difficult to do. Your preload is going to be pretty much wiped out, which means your cardiac output is also going to be wiped out. The regional blood supply, okay? What is the blood supply in the area of the target organ? If we have decreased blood flow going to the heart and we give our patients some morphine for chest pain, and we have decreased blood flow in the heart, it may take a little bit longer for that chest pain to begin to go away because it's taking longer for it to be delivered. Now, your medication storage reservoirs, again, within the body, sometimes it will hold up some of the medicine. The larger these reservoirs are, the more likely it is it's going to take longer. And then the last one is physiological barriers. What would be a physiological barrier to the delivery of a medicine to its target organ? Say it again, Isabella. Cancer could be one, yes, because it messes up, particularly within the lymphatic system, the ability of that medicine to be processed. Good. What else? Renal failure would be another good one, okay? One that I'm thinking of, and you guys will be learning about this if they're in the advanced sequence, is administration or the establishment of an IO. Literally, you'll take a drill, you'll drill a pretty good sized needle into somebody's shin bone or up into their shoulder, and we use that as an IV site. Now, let me ask you a question. Let's say that you've got an adult, cardiogenic shock, can't get an IV started. You started an IO on this patient, and now all of a sudden they convert into SVT, very fast rate. Now, we've talked a little bit about SVT, and for those of you who've been 303, you're the ones I'm kind of looking toward. Would it be a physiological barrier to give that medicine all the way down here when your target organ is up here? Why, Isabella?
Because it's going so fast that you're not getting the flow around, and it's farther down.
Not only, so yeah, so your heart is going fast, but what else?
Adenosine has too short a half-life.
And
It'll basically eliminate itself by the time it makes it to the target site.
yeah, it takes a little bit longer for it to get taken up into the bloodstream here. And even if everything were equal, from a physiological perspective, the distance from here to here is a lot greater than it is from here to here. And so think about those physiological barriers that come into play there, okay? Placental barrier, okay? The placenta will allow almost all drugs to reach the fetus, but it will filter out a certain number of them. The primary drugs that it allows to cross the placental barrier are lipid soluble. Now, what does a lipid soluble drug mean? Fat, okay? It's based in fat, so it moves across fairly easy. If we've got a mom in cardiac arrest, let me just establish this right away. We treat the mom, we pray for the baby, okay? Because the best survival of the best survival of the baby is survival of mom. We do not worry about what may happen to the baby with the ACLS or the emergency drugs that we give our patient. We'll talk more about this in a few weeks. We talked a little bit about biotransformation a while ago. Now, the big thing that I want you to know about biotransformation is called first pass metabolism, okay? What is first pass metabolism? Not the intestines. You're close.
It's the amount of medication that's first broken down in the liver before it's distributed to the body.
So that's part of it. So it is the amount of medicine that is metabolized or eliminated or neutralized as it passes through the liver. Not all drugs have this. Actually, I'm going to back up. Not all routes have a first pass metabolism. Actually, there's only one. What is it? PO. PO just simply means per oral or by mouth. We take a medicine in by mouth, it goes into the stomach, it gets absorbed, it gets into the intestinal tract, it gets absorbed, and the first place that it goes is over here to the liver as it passes through. Why is first pass metabolism important for you to be aware of? Tell me more. Why do we give a little bit more of the drug? Yeah, so basically what we have to do is sometimes we have to give a loading dose, okay? We don't calculate that ourselves, folks. People smarter than all of us have already done that. And so when you're looking at your drug dosages as we go through, and you'll learn about some PO medicines in here because, trust me, you guys are going to be given a lot more medicine within the next few years than you are right now. And particularly as you move into potentially becoming a community paramedic, you're going to be monitoring and administering oral meds. And so you got to be aware of that first pass metabolism effect to make sure that the patient is getting a therapeutic action level of drug. Martina.
So, you said that we need to do that, but wouldn't it be like segments like Tylenol or whatever that we can do PO, right? Don't they already calculate that because of the fast,
Yeah.
metabolism that they give more because of that? So we wouldn't be giving the same high dose as an IV because of it is giving more of it during the PO?
Yeah, generally what you're going to do if we were, we don't typically give IV Tylenol, but let's take Tylenol for example, okay? The amount that you're going to take orally is typically going to be a higher dose than if you take it IV. Why? Because if you take it IV, it travels through the venous system and goes right to the target organs. If you take it PO, it travels through the intestinal tract and goes to the liver, and then a portion of that is taken out. And again, it's kind of like what I was saying, and I'm confirming what you were saying. We don't have to calculate that. That's already been done by scientists and pharmacologists so that we know that the oral dose of this medicine is going to be different than, say, the IV dose. So, for example, you're going to learn about a drug in here called amiodarone. Good cardiac drug. Really, really good cardiac drug for both emergency as well as long-term use in patients. In emergencies, we give it IV. Patients that are on long-term amiodarone don't take it IV, they take it in a capsule form. And so you will begin to see kind of some of the differences in the dosing of these particular drugs, again, because of that. When we're looking at the word pharmacokinetics means what? Pharmaco is what? What?
Drugs.
Pharmacology, drugs. Kinetics refers to what? The action. So it's the action. So yes, kinetics does come into play here. But in particular, not only are we looking at the action, but we're looking at how it's absorbed, how it's distributed, how it is metabolized, and wait, there's more, how it is excreted. Do we get rid of it through our breath, through our urine, or through a bowel movement, or a combination of all three of those? Make sure you're familiar with that. Orphan drugs. Orphan drugs are drugs that are used to treat very rare diseases, and sometimes these are medicines that are produced in very small quantities to treat diseases that just don't affect a lot of them. Generally, an orphan drug will be developed, if it's developed. Now, again, drug companies are out there making money. I'm okay with that to a degree, but orphan drugs are typically administered to less than 200,000 people a year as far as the amount that they've got going on.
So it would be something to treat Ebola or something like that?
Yeah, potentially, yeah, because that's generally not a widespread type of disease. So that would be a good example, Richard. Yes?
I think of a patient this weekend, she has MAC, a form of TB, and she has to take antibiotics for the rest of her life, but it's not something that we do for us. So would that be considered orphan drug?
That would probably be more so off-label use of a well-established drug. So, for example, and I can't recall the name, Januvia, I think is what it's called. There's a diabetic medicine out there right now that is for type 2 diabetes. It's an injectable medicine. It's not insulin, but it's an injectable medicine to make the cells more receptive to the insulin that's produced by a person in type 2 diabetes. Some physicians will prescribe that off-label for patients who want to lose about 10 to 20% of their body weight, okay? So it just basically means this is your main reason for it, but we can give it for this over here as well. And so what you're describing is more of an off-label use of medicine. Good example, though. All right, so management of controlled substances. So here's the thing that you got to remember. Number one, your medication, controlled substances, should be under lock and key, and usually a double lock and key at all times. In the hospital, when you start your clinicals, you're not going to have access to whatever the brand, I always call them Pyxis machines. Basically, they're vending machines that dispense drugs and medicine in it. You have to have a specific code to enter in. Sometimes they use biometric information, uses your thumbprint, or maybe an iris scan or whatever. especially when you're dealing with controlled substances. So it has to be secured, okay? When you are giving a controlled medicine, you got to make sure that you are recording who you gave it to. So the medicine has to be tied to the patient. The medicine that you gave, the strength of the medicine, as well as how much you gave. So, for example, morphine. Generally, what we do with morphine typically comes packaged in 10 milligrams per 1 milliliter. We will generally dilute it out to 10 milliliters because what we want to do is we want to give somewhere between 2 to 4 milligrams initially. You're not going to be able to do that in a medicine that's constituted in 10 milligrams per 1 milliliter. So as you're doing that, then you want to hold on to that medicine because you may have to give an additional dose, Sydney, later on to the same patient, not to a different patient. When you're finished, now you've got to waste the medicine. Specifically, the way you waste the medicine is you keep the container, okay, and the syringe that it is in, and you have another person witness you squirting the medicine, usually down a sink or down a commode or something like that, and then you dispose of all that. You document in your patient care report, I wasted 6 milligrams of morphine sulfate on such and such a date at such and such a time, witnessed by, and then the person you would document who the witness is going to be in that regard. Sometimes EMS agencies will have a separate paper form that you must complete because they want that physical signature of both the person who is wasting the medicine as well as the person who witnessed it. But this is kind of the process that you're going to go through when you are wasting medicine, or not only wasting, but securing controlled substances, administering, and wasting it. Any questions on that? All right. Know the 4 types of drug names. If I give you that ethyl methyl bad stuff up on the top, know that that's the chemical name. The chemical name is usually a mile long, and nobody but the scientists that developed it can really pronounce it. Your generic name is just going to be simply an overall generic name for the medicine. It will often say what it's able to do. The trade name will be, especially for the company that holds the patent, will have a specific name for that particular medicine, and it can't be used for other types. So, for example, we're all familiar with acetaminophen. That is a generic name. Tylenol, on the other hand, is a brand name. Martina.
Do they not now like put? I can't remember which one it was, but you know they did like I guess it was a capital letter and a lowercase letter for I can't remember which genetic was a genetic and the trade name was capitalized or something like that. Remember?
So within both the generic and the trade name, depending upon how you get it, they will utilize what's called tall man lettering, and they will capitalize and bold part of it to hopefully draw your attention to the fact that this is a medicine that has another medicine that sounds similar. So, for example, adenosine and amiodarone do have some similar sounding name or similar sounding sounds. But trust me, they affect 2 entirely different parts of the heart, as well as they have different effects on those parts of the heart. And so when you're looking at it, especially from the trade name, what you will often see is that a trade name for adenosine would be adenocart or adenocard. C-A-R-D. They will capitalize the adeno part of it to draw your attention that this is adenosine and not amiodarone. Within amiodarone, the trade name for amiodarone is cortisone. And many times what they will do is that they will capitalize the first few letters of cortisone to, again, draw your attention to the fact that you're wanting to give cortisone and not Adenocard. Very good point to bring up. Excellent. And the last one is the official name, which is always followed by the letters USP. Anybody have any idea what USP stands for?
United Standards of Pharmacology.
Close. It's the United States Pharmacopoeia. The Pharmacopoeia is a legal repository online that has all of the medicines that are legally able to be administered in the United States. Okay? One of the places that you can find a USP is a resource that I recommended to you at the beginning of class, and that's Hippocrates. Hippocrates taps into the USP, and any drug that is legally able to be given in the United States, you can have access to figure out what it does, side effects, contraindications, different things that you come into contact with. Because trust me, you're going to run patients that you're going to go, I've never seen that drug in my entire life. You need to have something where you can look it up, all right?
It also tells you the enzymes that it's metabolized and things like that.
Oh, it gives you all kinds of tons of information, more than what we could ever utilize in this class. But make sure you know the 4 names of a particular drug. Why do we start IVs? What are the 2 primary reasons? Fluid replacement is one. What's the other one? Electrolytes, that's actually, you're coming closer now, Martina, to the second reason. What's the second? Say it again. Give medications. So the 2 primary reasons that we start IVs, give medications, electrolytes, and to do fluid replacement. Intracellular and extracellular fluid. Now, the larger of the 2 compartments is the intracellular compartment. Okay, the intracellular compartment. When we're looking at this includes all of the blood that is, not blood, all of the fluid, the liquid that's found within the individual cells of the body. 75%, Sydney, of the body's fluid is within the intracellular fluid compartment, i.e., within the cells themselves. The remaining part of the fluid is found outside of the intracellular. So 25% is outside of the cells themselves. Now, when we're looking at this, we're looking at 2 components of the ECF, or the extracellular fluid. One's found in the blood vessels and outside of the membranes, and the other is the interstitial fluid that is not within the blood vessel, but it's also not within a cell itself. So the cells basically are kind of bathed in this fluid that is interstitial fluid. Now, the word homeostasis means what? The body's tendency to try to keep everything in balance. When our sympathetic nervous system kicks into drive, we secrete certain hormones like epinephrine and norepinephrine that kick up the heart rate, that kick up the respiratory rate, that cause bronchodilation, that get us ready to fight, flight, or flee. The body doesn't want to be like that all the time, so then it kicks in other hormones over here from the parasympathetic system that keeps us in a nice balance, okay? Just understand that the word homeostasis itself just simply means balance. Electrolytes. All electrolytes are not measured by milligrams or milliliters, but they're measured in milliequivalents. Milliequivalents. What are the major electrolytes that we have that we're focusing in on as a paramedic? Potassium, calcium, sodium, magnesium. Those are the four that you need to know. Now, I'm not going to ask you what their concentrations are in the body or in lactated ringers or anything like that, because to be quite honest, I don't know them myself. So if I don't know them, why would I expect you to know them? Okay. Now, within the extracellular fluid, generally what we're going to find the greatest concentration of is sodium and calcium. Potassium and magnesium are within the intracellular space. Now, this is going to be really important, guys, when you get in, those of you that are not yet in to the advanced sequence, when we begin talking about the sodium-potassium pump. Moving sodium and potassium in and out of the cells helps all of our muscles to work, but in particular, it helps this muscle to work, the heart, and it moves back and forth. In particular, if we have imbalances in our electrolytes, bad things can happen. If we have a low sodium, what kind of problem can we run into? Blood pressure could drop. You're exactly right. What else?
Fluid buildup,
Not with a low sodium.
low sodium.
Now remember, say it again, Isabel. Yes, that's where dehydration comes into play, therefore leading you into cramps, which are really, really painful, all right? And so those are the things that are really, really important to understand. So let's take a look at some of the individual processes of the electrolytes. The first one we're going to look at is sodium. Now, sodium is the most abundant electrolyte that's found in the body. And Richard, you were spot on there a while ago when you were talking about water. One of its main roles is to help with the regulation of water. What was the little saying I said about sodium in water? Sodium sucks. Yeah. Where sodium goes, so does water. So if we have an increase in sodium, we're going to have an increase in the retention of water. Now, for healthy people, that's basically just an inconvenience. You go eat at your favorite Mexican restaurant. The next day, your eyes may be a little puffy. Why? Because you have all that sodium that makes that Mexican food taste so good. Now it's within your body, and your fluid is staying there as well. Could be deadly for a heart failure patient. Why? Because their body does not regulate fluid as well as, say, yours or mine does. Could be deadly for a renal failure patient for the same reason. So that's why sodium has to be regulated. And again, as the roles of paramedics begin to evolve, you guys are going to be checking these electrolyte levels on patients that you're going to be going out at some point in time if you decide you want to move into like a community paramedicine role. Sodium also has a role to play of how quickly the nerve impulses are passed along through the body and how quickly calcium can move into and out of the cell. Why would the transfer and the speed of calcium movement into and out of the cell be important? What does calcium help us do? Contract. So if you've got a low calcium level, guess what? We're really concerned about not contracting. Okay. Again, you can see this in patients that have renal failure. If they go to dialysis and within an hour or two after they come back from dialysis, if they're in cardiac arrest, and we'll talk more about this later, but be thinking, this patient may be too low in calcium. We have one of two medicines that you can give them that's not going to hurt them if it's not low, but could indeed restart their heart if it is low. Now, when we're looking at the regulation of sodium. This occurs most often where? In the kidneys. Yep. And so this is why, again, if a patient has renal failure, they're not able to regulate that sodium. It stays within the body, and it increases the possibility of our patient having pulmonary edema as far as putting them into heart failure. Now, the hormone that regulates within the kidneys itself is called aldosterone, ALDOSTERONE, not Toblerone like the toffee candy that's so weird, but aldosterone. When it is secreted, it helps to it helps to increase the renal function to get rid of sodium. Therefore, when you get rid of sodium, then you're also going to get rid of your water as well. Again, keep in mind that an imbalance in sodium, either too high or too low, can lead to an imbalance of water, too high or too low. In America, we're not too concerned about sodium levels being too low, although that can happen, in particular, if you're out working outside in the summer, it's hot, it's humid, you're not drinking enough water, you're not eating enough, and your sodium levels begin to fall, okay? Any questions on sodium? All right, calcium. We know calcium is good for our bones and our teeth. Your mom was right. Drink your milk, okay, so that you have strong bones. But did you also remember us talking about the fact that if you have a patient that's low in calcium, they will also not clot as well? Again, this is one of the reasons why you want to watch patients who have some type of renal dysfunction, because the levels of calcium in renal failure patients are also very low. So if you've got a trauma patient that's a renal failure patient, you want to watch their bleeding really, really closely. It also helps to maintain the stability of the cell membrane. Why is that so important? What happens when the cell membrane breaks down? Say it again. Cell dies. And what happens if we have enough cell death? Well, definitely the pH is going to change. Acidosis. But ultimately, we have organ failure. And that's what we see in situations of shock, where we have inadequate blood flow going to the different organs. They become very hypoxic. Acidosis increases. The cells now begin to swell up. The membrane ruptures, and it releases, in particular, what electrolyte? I'll give you a hint. Capital punishment. Potassium. Potassium. A large portion of the body's potassium is contained within the cell. As long as that membrane is intact, it's all good. But when we begin to get widespread cell death, it releases that. And if we get a massive dose of potassium going to the heart, our patient can go into cardiac arrest. Now, when we are looking in the body, most of the calcium within the body is found obviously within what? Bone, okay? But there is some that can be found within plasma, as well as within red blood cells. That's what they're measuring when you go in and you get a CBC, complete blood count, and they're looking at some of these different levels, or for your calcium level. That's what they're measuring, not the amount that's in your bone, but the amount of free calcium that is floating around. Again, calcium is incredibly important for mechanical action of the muscles, in particular, mechanical action of the heart. Now, there is also a very close relationship between calcium and vitamin D, okay? Vitamin D is produced by the body in response to what? sunlight. So if you want to have more calcium available for the body to utilize, spend some time outdoors every day. Now, we can supplement that with a vitamin D supplement, and some people have to. People that are anemic, people who are in heart failure. Again, renal failure patients have to supplement that with a vitamin D. But they also encourage these patients to spend as much time outside, especially in the hours between 10 and 2 of when the sun is at its highest, to help to facilitate the production of vitamin D and the production of calcium. Isabella.
Why do you take vitamin D for anemia?
It is a helper type of drug. So it's much like glucose can't go into the cell by itself unless,
I thought it was vitamin C.
say it
I
again,
thought it was vitamin C that opened it up for anemia. I don't know. I didn't know I was supposed to take vitamin D. This whole
vitamin B is what we use for anemia. It helps to increase some of the red blood cells. D delta is what I'm talking about.
Yeah, I just didn't know I was supposed to take D.
Yeah, D supplements help just to move that calcium around. It's actually kind of like a potentiation type of drug. All right, good. Anything on that? Well, you guys are quiet. I hope you do well on this exam. Potassium. Potassium's required for nerve transmission. Okay, potassium is an incredibly important drug for heart rhythms. You get into cardiology, you'll learn that T wave, those of you that are in 310 are getting ready to find out the importance of looking at the T wave and what it can lead to as far as additional information for your cardiac patient. Potassium also has a role to play with glycogen stores. What is glycogen? Say it for me one more time.
like make or take out glucose so that the body can use it.
You're talking about for glycogen? Yeah, so basically what comes in is, and both you ladies are right on the money. We take in glucose by what we eat. Some of it gets stored in the liver, but the liver can't store glucose. So we have potassium that comes into play, as well as other enzymes, and converts it over into glycogen. Glycogen can be stored in the liver, okay? Then the reverse happens as well. When the body's blood sugar level drops, and we need an emergency dose of medicine or an emergency dose of glucose, the brain sends a message to the liver, and now, again, with potassium as well as other hormones and enzymes, it takes that glycogen, pulls it out, and reconstitutes itself. It's kind of like dehydrated meals. I don't know if you've ever camped. I know I don't look like it. Years ago when I was your age, I used to do a lot of backpacking. You have to trust me on it. I carried a lot of dehydrated meals, and this was just food that had all the water pulled out of it. Got to the campsite at night, time for a meal. We'd add hot water to it, let it set for about 15 minutes, and boom, it reconstituted itself into something that was edible. I would never have eaten it when it was dry. It would have been nasty, and it would not have stayed down very long. But once I reconstituted it, now it comes out and is very palatable. That's what happens with glycogen. It gets changed back from glycogen into glucose. Y'all will learn about a particular drug that will facilitate that, but it can be very dangerous. Martina?
I'm a stupid person, so in my mind, liver just goes off and says, here, take this before I die, or whatever, but, okay. Far from where I was going.
Okay.
Anyway, so, all right, we get to the big three, right? And so we're on shop, okay, so we got the big three. Why is liver not one of them if they're the one that actually, so basically, after it throws out its last absorb. That's how I feel like it goes out the glucose. It's like, hey, take this or whatever. So we can only use the amount that they had gave us left. So that means that we have a shorter time to get everything together. And like the big three only live for so long.
Mm-hmm.
So I know you're not God. So I don't know why the liver would be one of the three that.
So here's and what Martina is referring to, and I think all of y'all have heard me refer to this, is that the body will try to perfuse the big three at all costs. And the big three are, in this order, the brain, the heart, not the lungs, but the kidneys. And so it's kind of like the kidneys. I can get the brain, I can get the heart, but why the kidneys? Okay? The brain, because it is the most important organ we have. It is what makes us who we are. Claire, that's why you're Claire and not Bill Young, which is a very good thing. Okay? The heart, obviously, because it's got to perfuse the brain. Okay? So why the kidneys? Understand, and I think those of you that are in medical emergencies, you'll learn a little bit more about this when you get into respiratory emergencies, is that remember, we talked about homeostasis. Homeostasis is what? Balance of the body. Okay? The body likes to be balanced. There are multiple ways in which the body balances itself. One of the primary ways is by way of what's called the buffer system. The buffer system is either adding a little bit of acid or a little bit of buffer or alkaline always into the body to keep us at an even keel pH. Guess where the buffer system is? Kidneys. The kidneys. A slight variation in our pH means we die. And so that's kind of why I think why the kidneys would be number 3. Now, that doesn't mean that the liver, the spleen, and everything else that we've got is not important. But the body's just designed so that it falls back to perfuse those 3 at all costs, hopefully for just a short term, till we can get our patient to definitive care.
Is that why we started IV to try to give them the glucose and the.
We can, and again, when you're dealing with patients in shock, one of the things that you should do is to check a blood sugar, because remember, they're going through that glucose really, really quickly, and it pulls that glucose down. When you're under stress, it pulls glucose down. It's really interesting. This weekend at church, a friend of mine was teaching the lesson, and he's a type 1 diabetic, and he's got one of these little machines that monitor, and he was talking, and all of a sudden it set off this loud alarm, and I knew what it was, and he knew what it was, and I was watching him really, really close because I knew his blood sugar had dropped. Now, he's a really good teacher, but man, he gets so stressed out before he teaches, and that stress ate up his reserves of glucose. Luckily, his wife was there. She brought him up some compressed glucose. He ate 3 or 4 tablets of it and never missed a minute. But again, when the body is stressed, I tell you that, go ahead and check the blood sugar on your trauma patient, okay? In particular, to see if potentially do we need to increase the glucose. That was a good discussion. So as we're looking at this, potassium works really closely with sodium as well to move across the membrane back and forth, so that we can have that electrical impulse going through. Hence, the sodium-potassium pump. Now, again, sodium, potassium, and calcium all work pretty much together. Again, sodium, potassium for the electrical action that stimulates the cell, the calcium for the mechanical action that pushes things across. The other electrolytes you need to know about is magnesium. Magnesium is about half of it is stored in both your muscles and in your bones, particularly in your long bones. The rest of it, the other half, the other 40% or whatever, is stored within the cell of the body itself, okay? It's also impacted by the levels of potassium and calcium that is within the cell. So when those go up, magnesium go up, and the reverse is true as well. So what role does magnesium play? Well, magnesium helps to build ATP, and ATP is what? That's what we utilize for energy. If we don't have enough magnesium, guess what? Our ability to make ATP goes down. And ATP is the source of energy for that little pump that we talked about, Isabella, the sodium potassium pump. So again, if magnesium levels are low, ATP falls, sodium potassium pump fails to work, which means our muscles are not working, and in particular, our heart is not going to contract the way that it should. When we give a patient magnesium, it causes smooth muscle relaxation. That's going to be really important because sometimes we're going to give magnesium to patients who are having specific EKG dysrhythmias. For those of you in the sequence and those of you who have been through 303, remember torsades? Our primary treatment for torsades is going to be magnesium. Those of you that are EMTs, you remember talking about eclampsia and preeclampsia in your EMT course? We give magnesium to help keep our patient from moving from preeclampsia into eclampsia and having seizures. When we do that, we've got to watch them closely because remember, it's a smooth muscle relaxant, which means what for our patient? What is it going to do for our patient? It can dilate the vessels, having an effect on the blood pressure, lowers the heart rate. It does what? Yes, so we get a decreased altered mental status of our patient, which can lead to airway problems. So see, simply because it's an electrolyte, and it's a natural electrolyte that you get from food, and you're going to be administering, does not mean that it doesn't come without certain risk, and that's why it's important for you to know that. Martina.
So when it dilates the vessel, it dilates the vessels more and it actually gives more fluid into the brain to give it pressure.
Yeah. So the blood that goes into the blood vessels is a good thing, but the magnesium is there to kind of turn off the electricity of the brain so that it lowers or raises the threshold, not lowers, raises the threshold for the ability of our patient to have a seizure. Seizures are not good, especially in pregnant patients, because what do patients that seize not do? They don't breathe. And if mom's not breathing, who else is not breathing? The baby is not breathing. All right?
With pregnant patients, don't you double the dose of magnesium?
You do have a specific dose of magnesium, and we are going to cover that in here. So you'll get into dosing, in particular, looking at things like tocolytics, which help to speed up or slow down labor, as well as mag. So yes. Diffusion is what? High concentration to a low concentration. It does not have to cross a semi-permeable membrane, okay? If it does cross a semi-permeable membrane, it's known as osmosis. Osmosis. Bless you. Isotonic. When the concentration of fluid on both sides of the cell membrane are equal, okay? Not the volume, but the concentration, it's said to be isotonic. So the way I like to illustrate it is on the inside of the cell, the percentage of sodium is the same as on the outside of the cell, then it is an isotonic solution.
So does that mean that like if you're giving isotonic fluid, does that mean that it won't flow into the cell?
It's exactly what it means. Because remember, fluids will also, or concentration will move from a higher concentration to a lower concentration. If it's equal, it's not going to move, okay? But what if it's hypotonic? What if the concentration of saline on the inside of the cell is lower than that on the outside of the cell?
Fluid from the outside is gonna go into the inside.
Sodium is going to move in. And remember, sodium sucks. The water is going to go in as well. If that happens too fast, what do we see? I like that. Yeah, rupture of the cell membrane. Okay, if we have enough cells that rupture, now we have a big problem. Okay. Now, when we're looking at hypertonic solutions, we're looking at things that are higher on one side than on the outside. Now, when we're comparing different types of IV fluids, understand that lactated ringers and normal saline, which is basically 9% saline or sodium chloride, are isotonic solutions. They don't cause massive shifts in water.
Isn't it 0.9%?
Point nine, I'm sorry, did I say 9%? Thank you. Thank you for correcting me. 0.9%. So we don't see these massive shifts. So these are isotonic. They're still considered crystalloid solutions, okay? Now, a good example of a hypertonic solution would be, and we'll talk about this in here, is the drug we used to give a lot of 50% dextrose. It was like pushing syrup into a vein. It was that thick. Very, very high concentration, 50% glucose coming into here. All kinds of problems. We'll talk more about that when we get into diabetic emergencies. Generally, we don't use it a whole lot anymore because, like I said, it can cause massive swings in different areas. Last thing I want to talk about before we go is blood, okay? Blood is responsible for the transport of oxygen, the movement of nutrients, the movement of hormones through the body, as well as the movement of waste products out away from the cells. Blood is also responsible for temperature regulation. Red blood cells are little heat-carrying vehicles that when you lose them, your patient becomes hypothermic. Now, blood is made up of plasma and formed elements. Plasma is the liquid part of the blood. The formed elements are red blood cells, erythrocytes, white blood cells, leukocytes, and platelets.
Aren't erythrocytes and red blood cells the same and vice versa with leukocytes and white blood cells?
Isn't that what I said?
You named both of them.
Erythrocytes is what I meant to say. Red blood cells are erythrocytes. White blood cells are leukocytes.
Yeah, you're just saying fancy names. You're saying the
Okay.
same thing, fancy names.
Okay, yeah, but you need to know them both. You need to know them both. And then platelets, okay? The blood is made up of 92% of plasma. And the other thing as we close this out is that carbon monoxide can be dissolved in plasma to be returned back to the alveoli, okay? So we will stop there, and then I will finish this recording and get it ready for you. We've got about